morning, good afternoon, or good evening to all our listeners, wherever you're joining us from around the world. I hope that you are staying safe in light of recent events, and I'm praying for everyone's safety here in the Middle East. My name is Sylvie Malouf. I'm going to be moderating today's webinar. This is DiaLeb's 7th Annual Women in Diabetes panel, Empower Her Health, Bridging Women's Diabetes Care. I have an incredible group of ladies here, and I can't wait to speak to them all. But before we start, I would like to introduce Dr. Jackie Malouf, who is the president of the National Diabetes Organization, DiaLeb, who will be giving us a few remarks.
Thank you, Sylvie. I will start by saying in extreme times, we need extraordinary measures. And we are all aware of the difficult circumstances in the Middle East that the Middle East is facing today. So here I am joining from Beirut. Sylvie is joining from Qatar. And despite the challenges, we chose to continue with this webinar because diabetes does not take a break during war or crisis, and neither should our commitment to people living with diabetes. So as we connect with you, our thoughts are with every person, especially those living with diabetes, as they navigate those very, very difficult times. So I welcome all of you joining us today. And I would like to tell you that this year marks DiaLeb's 15th anniversary. It has been a journey marked by challenges and successes, moments of strength and moments of vulnerability. And today we recommit ourselves to doing more, reaching further and speaking louder for those voices that must be heard. So allow me to welcome you to the 7th edition of this featured International Women's Day webinar organized by DiaLeb, a platform we are proud to sustain year after year to ensure that women's health remains visible, valued, and prioritized. So today, it's not only a celebration, it's a call to action. It is also a moment to acknowledge that powerful changes happen when women unite across borders and experiences. It is my great pleasure to welcome our distinguished panelist, Dr. Niti Pal, whom I am very proud to call my friend, the president-elect of the International Diabetes Federation, a leader I deeply identify with as we both are mothers of children with type 1 diabetes. We are also joined by Linksy and Renza, outstanding women diabetes advocates whose voices continue to inspire change, break stigma, and amplify lived experiences at global levels. And a big thanks go to Sylvie, our moderator, who is the co-founder and managing director at DiaLeb, especially for joining under these stressful moments. Her dedication and leadership continue to elevate conversations like this and turn dialogue into meaningful impact. With that, I am delighted to give the floor to Sylvie to moderate this inspiring panel conversation. Thank you.
Thank you so much, Jackie. As we start this conversation, I just wanted to bring about, we always host these talks on the back of International Women's Day, and usually we celebrate strength, right? But tonight we're going to talk about something a bit deeper than strength. It's really about talking about visibility. As was mentioned, as a woman myself living with type 1 diabetes for almost 20 years, I understand firsthand what it's like to manage numbers in silence. We carry the invisible calculations, the insulin doses, the glucose levels, the ups and downs, and we try to do it all while living in very difficult circumstances and also carrying the expectations to show up, care for others, to succeed, and to endure, because the expectations of women are that high. We navigate on top of all of that systems that were not designed around our realities, often with realities that are overlooked for what it means for a woman to live with disease, and in particular diabetes. At DiaLeb, we believe empowerment is not just personal, it is structural. And for us, empowerment, it means access, affordability, gender responsive care. And it means that women are not only receiving healthcare, but they are shaping it. This year's Women's Day is about giving to gain. So it emphasizes the power of reciprocity, support, And we highlight key gaps and disparities in women's diabetes care, which continue to abound. And therefore, we have these incredible women that you've introduced already who are leading advocacy, they're leading change in health systems, and they're incredible voices, promoting awareness, increasing research, and giving attention and care for diabetes at large, but for women and diabetes as well. So I wanted to have this discussion to be a little ambitious. I mean, we want to leave not only inspired, but a little committed to building systems that really see women, hear women, and design with women. So let's begin. Our first speaker for tonight reminds us that expertise does not only live in institutions, but it lives in experience. Lindsay Mitcoli is a systems strategist and director of patient engagement at Diabetes Action Canada. She has founded a Research to Action Fellowship, which is a national program that supports people with lived experience to translate research into community-led plain language resources. She's a first-generation Albanian Canadian who lives also with type 1 diabetes, and she brings what she likes to say, lived, loved, learned, and labored expertise to her work. She's also one of the founding board members of Voices in Action, Global Advocates in Diabetes, who I am also part of the steering committee with, and works a lot on stigma reduction. Lindsay, you often speak about bringing this lived, loved, learned, and labored expertise into health systems. How can women with diabetes move from being seen as just patients to being recognized as co-creators of research and care systems?
Thanks, Sylvie. And first, thank you for your visibility today. I appreciated the context that you set, and it's not lost on me that your visibility is part of the impact of today's event. So thank you for that. So the 4 L's, I'll start off with some level setting and some context. I talk a lot about how expertise shows up in different shapes and ways, and I like to organize my thinking and my language around expertise, around lived, loved, learned, and labored expertise. So lived expertise would be, I have a diagnosis on my medical chart. I know what it's like to live with diabetes. I bring that angle of expertise and experience. My husband has loved expertise. He'll never know, hopefully, what it's like to have diabetes. He knows what it's like to check if I'm still breathing at night, if I have enough glucose tabs, and I don't know what that experience is like. And he has a unique set of expertise that he brings to this reality of diabetes. I have colleagues that have studied islet cell production day in and day out for 30 plus years, and they have learned expertise of diabetes. I can't replicate that, and that's important in diabetes discussions as well. And last but not least, there's folks that bring labored expertise of working day in and day out in diabetes. There's nurse educators and doctors and community workers and even folks in an emergency room or emergency preparedness. They know what it's like to respond in a work setting to diabetes, and that part is important to the diabetes discussion as well. Why is it important to put words to expertise? Well, words like the 4 L's give us the framework to organize our thinking, but frameworks help us also organize power and influence. So the way that I explain it is that when we put the 4 L's on a level playing field, it means that we have to now honor, respect, and treat lived expertise in a way that we do and loved, in the similar ways that we do with labored and learned. So when we talk with researchers or clinicians, we know and have this unspoken understanding that inclusion is not enough. We're talking about authority because co-design is about having shared authority. Inclusion is about just being invited to the table. And being invited is not enough if no one's listening to your voice, if they're not sharing. Chelsea Rice has a great analogy. Renza usually quotes it, but today I get to beat her to the chase. We want to build the table ourselves too. We don't want to just be invited to your table. What if I can't sit at your table? What if the meal you're serving doesn't suit me? So organizing our thoughts around the different levels of expertise allows us to organize structures of shared authority. And I think that's really the only way, and I'm going to actually paraphrase your question and say, I don't think it's actually women's work to change the way that we are seen. I think it's the system's work to change the way that they share authority with us. It's not enough to say, I have a woman with diabetes on a panel. I have a woman with diabetes on my research team. Does that woman have shared governance role? Can she vote on decisions? Does she have access to the budget? Does she have access to strategic priorities, but also shaping what those strategic priorities are? Are we shifting the women with diabetes role from invitation to co-creation and shared authority? The last point I wanted to make, and I've been thinking about this a lot in preparing for today's webinar, is I think 4Ls is actually not enough. And I don't know what the fifth L is. I've kind of landed on, you know, women in the diabetes ecosystem. We often have all 4Ls of expertise of learned, loved, labored, and of course lived. But it's not lost on me that we do the majority of the lifting in the community work as well. We lift others around us. We lift strategic priorities. We do a lot of unpaid labor to get access to our community members to what they struggle to have access to. And I think that type of community care and leadership deserves its own L as well, because that work tends to be invisible to the outside world, but not to those of us who are in the community. It's the work that actually sustains the community. So I'm not sure what the fifth L is, but I'm going to workshop that one, and I think it needs an update.
All right, I think maybe we'll have some, maybe we can get suggestions from our listeners on what that fifth L should be, because I think it's a brilliant point that you make. And thank you so much for reminding us about the experience and the different forms of experience, and how it's not just anecdotal when we talk about lived experience, it's actually data, it's leadership, it's evidence, and how, I liked what you said about how we can shape the system to ensure that inclusion and not just wait for the representation. And our next speaker, she actually works at the systems level. Dr. Niti Pal brings decades of experience building primary care models and advancing universal health coverage across continents. She is a medical doctor of KPMG's global health practices in the UK. She's in the UK. She's a visionary senior clinician who has combined clinical practice with entrepreneurial edge to design and deliver new models of healthcare around the world. A proponent of universal healthcare and coverage, and a general practitioner for over 30 years. She's helped to build up primary care clinics across the UK and had several senior roles where she supported healthcare change in India, Bangladesh, China, Hong Kong, Saudi Arabia, and so much more. And she's also the president-elect of the International Diabetes Federation. Thank you so much for being with us today, Dr. Niti. You've built and led primary care systems across the UK, India, Asia, as I mentioned, and many other markets. And from a global perspective, what do you see are the health system gaps, and why are they failing women with chronic conditions like diabetes?
That's a very interesting question. I didn't quite count on that one, but thank you for that, Sylvie. So having worked in about 44 countries around the world now, so I'm still counting. It's been an interesting experience on universal healthcare. You find that there is two sides of this coin. There is folks with diabetes, folks with chronic illness that are accessing healthcare in many, many systems differently. Two, on the other side, is the health system itself. And again, if you look at health systems worldwide, the majority of the workforce is women. And actually, a boss of mine in KPMG wrote a book called Human. It's about the global workforce crisis in healthcare. And one of the chapters is about women and work. I really recommend it. Read it if you guys haven't. It's about what women contribute to the health of many, many systems. The problem really is a lot of these women get stuck. And if you talk about women in leadership roles in health systems around the world, they're not many. You still have blokes there. So, while most of the workforce is made up of women, you don't see the same coming across in senior leadership roles. So how we create our health systems is also quite telling, and in that book, Mark talks about if we don't use women's work more thoughtfully, just as you said, Lindsay, we're not going to be able to co-create with our patients what they need. So that's one side of the coin. And then on the other side, you have people with diabetes and accessing care. Some of the countries that I work in, I work a lot in low and middle income countries these days. I work alongside of inclusive insurance products. So these are insurance products or coverage, financial coverage for blue-collar workers, gig workers, people don't have proper jobs, but are working in factories and other places up and down. And a lot of them are micro-entrepreneurs, and micro-entrepreneurs generally tend to be women. They're the ones who supplement household incomes. They're the ones who supplement where their children go to school. And most of the access to healthcare is done by women in the household. So if you look, and we've done lots of studies around this worldwide, and we find that it's women who access healthcare on behalf of their families and their kids. I know I'm straying off the diabetes topic, but I think it's the really important one to know. So, and it's been the same worldwide that I've found it's been mostly women that access healthcare for their families. So if we don't involve women in the creation of what matters to them, you're not going to get what you need. Chronic disease management is somehow thought, especially some of the countries that I work in, that it only affects men and it doesn't affect women, which is really strange. So women have their cardiac diagnosis delayed by about 10 years sometimes in some countries. Their symptoms are not taken seriously. And it's the same for every chronic disease. It's multiplied every time. And I guess because of that, women get left behind as well on the inequality roadmap as well. Even though they are the ones to access healthcare for their families, they get left behind. And it's every country has been similar to some extent. Because in healthcare, only 4 things matter, and it's the same everywhere. It's trust, empathy, expertise, and information. In that order, always. And if the trust doesn't happen, then the empathy doesn't happen, expertise and information doesn't follow. People don't take it in. They don't take what's to come in. So I guess what I'm trying to say here is both sides of the coin needs to be looked at. My experience as a mother, a Black mother, brown mother of a son with type 1 diabetes in the English healthcare system was very mixed. We have the UK NHS. I had a brilliant home care team when Jeve, my son, who's now over the age of 35, was diagnosed at the age of, he was just 4. He had not turned 4 when he was diagnosed with type 1 diabetes. I am a doctor, but when I walked into the clinic, I was treated as an illiterate brown woman. So nobody actually listened to what I was trying to ask them till Javier, my son, was old enough at 7 to pipe up and say, why do you treat me like this? Why do you all want to see me for an hour each? Why don't you all sit in the same room? You all ask me the same questions. Can't you change the way you see me? Can all of you sit in one room and see me for 1 hour together and ask me the questions that you all seem to be asking the same questions? They listened to him. I'd been saying that for about 4 years, nobody listened. So I think it's not just about, as a woman, you have a double whammy if you have a different skin color too. So again, I don't want to labor that point, but it's, you talked about love, and I don't know whether that's the L. I don't know where that comes. It's a really difficult one, that inclusion bit, and we can talk about it till the cows come home, but it's really difficult for some folks because they don't get heard. And if someone like me, who's pretty used to getting heard and who can fight my way through most systems, found it difficult, I felt patronized. I felt that people weren't listening. It's not an easy place to be. So, I'll stop there. But Sylvie, I think there are many women who might be listening who might echo what I had to feel as well.
And you've highlighted, a lot of interesting things, that it's not just a sentiment, that it's actually in the systems, right? When things are delayed, when checkups are delayed, when the conditions are not taken seriously, and the unfortunate reality of women seek out care for others and then they end up being left behind is so powerful. So it shows us that we don't just, you have policy and you have infrastructure, but that is not enough if we don't shift the culture and how people see you and how we're inclusive. And our next speaker, if I can go to Renza. Renza Sibilia has spent over 2 decades challenging the way diabetes is spoken about, it's designed for and represented globally. Through her advocacy and the powerful principle of #nothing about us without us, she reminds us that inclusion is not just symbolic, it must be structural. Renza has lived with type 1 diabetes since 1998. She is a diabetes advocate and a senior director for global responsibility at Breakthrough Type 1, formerly JDRF. She has worked for diabetes organizations for over 25 years, promoting person-centered approach to development, design and delivery of diabetes technologies, services, researches, and education programs. She's also a global head of advocacy for DDoC, which is a European-based organization that provides opportunities for diabetes advocates from across the world to become part of networks and attend convenings and other events. Renza, it's great to have you. I know it's very, very late or early in where you are, but being such a powerful voice for person-centered language in diabetes care, why does language matter so much for women, particularly living with diabetes, and how can it enforce or reduce the stigma?
Thanks so much for the question, and thank you so much for the invitation to be part of this panel with an incredible lineup of stellar women doing amazing things in the diabetes space. I'm so glad that we have questions about language, but I will say, I think when we really first started, talking about a Language Matters movement, if you like, that was accompanied with position statements, because that wasn't really the start of the language movement. People with diabetes have been talking about this for years. But I think one of the things that perhaps we did, just because hashtags were very in at the time and we needed one, we said language matters, which it does. It absolutely does. But really, it's much broader than that. It's communication matters. And I think one of the things when we sort of narrowed it to language was that people thought that it was just about individual words, and people use words differently to mean different things, and people with diabetes use words that resonate with them and their own diabetes but may not with somebody else. And we suddenly got into all of these debates about, is this the right word, is that the right word? It's more about an overview, if you like, around communication that includes more than words. It includes images, includes attitudes, it includes the ideas about how we speak about and how we feel about diabetes more broadly, how diabetes is represented. And I think for women, there are specific challenges there. We know that healthcare is a very difficult space for women. Medical misogyny is very well documented. We are living in a very paternalistic and patriarchal system. Women do face extra challenges, and that is very, very present in the diabetes space as well. So when we offer all people, not just women with diabetes, because I also feel, as Lindsay did, this can't be something else that is on our shoulders along with everything else. It's about structural change. It's about the community changing. It's about the medical system changing as well. But when we provide a framework for that, and we offer ways that people understand why it is that language is so powerful, that communication is so powerful, that it is so impactful, that it can be harmful, we can open up those dialogues so that we can actually start to see change. So a couple of years ago, Jazz Sethi at DiaBesties led some work on a language statement specifically for women, and very wishily it's called Language Matters. And it's interesting because it provides some really interesting, points of discussion around that. For women, diabetes discussions seem to start and end around pregnancy and birth control. That seems to be it. That's where it's really important. We're starting to see a shift in that because the community is demanding it. So we are starting to give people, the questions to ask around perimenopause and menopause, around periods and menstruation. We're giving young women the tools and helping them understand that they can walk into a clinical appointment and say, actually, I don't want to talk about pregnancy. This can't be the only thing that you speak with me about because I am living because I am a woman. And I think that that's been really one of the real powerful parts of the diabetes language or communication movement, is providing those ideas and points for people to be able to take and to have broader discussions around what diabetes means, for women. And I think that is really, really important, because it has been, I think, quite challenging for a lot of people who, are dismissed when they're going in with queries and questions, and they're told, well, that's so, as a woman of my age, it's often, well, that's just your diabetes, you've had it for 28 years now, or that's just part of being a woman. Now, I have the tools to not accept that, and I would like, to think that we are providing language options for people to be able to challenge, just those dismissive sort of comments that we get and say, well, actually, I'd like to dive a little bit deeper into that, because really, sure, you're telling me that my painful hands could be because I've hit perimenopause, but also it could be arthritis. Could we just make sure that that's not what it is, and that I'm, getting treatment for what I need? So I think, the Language Matters movement has been very, very important. It's also formed the foundation of all the work that we're doing in stigma, and I think we'll be talking about that a little bit more later today. But I think that, having these conversations around why communication is so important and how it can harm, but also how it can really elevate the experiences of people with lived experience of diabetes has been really very, very important. It's been going now, if we sort of date it from the first position statements, it's 2011. It's 15 years. There's still a long way to go, but I think we have certainly made a good headway into recognizing that, the way we communicate about diabetes is really, really important.
Thank you so much for that and for all the work. And language is so important. Maybe that's the fifth L you were looking for. We can find a way to make it linguistic experience. I don't know, something like that, Lindsay. I wanted to go to build on that. And Lindsay, you have this Research to Action Fellowship, and there's an upcoming book, I believe, called Things I Learned the Hard Way, which highlights the lived lessons of women and how they had to learn them independently. And that resonated with me so much, I already want to read it. Could you tell us a little bit more about that? And also, you do a lot of work on stigma. What do you have planned in terms of that kind of work as well?
That's like asking me, what do I have planned for the rest of my life, God willing. But I'll start with the first part of your question, Sylvie. So the Research to Action Fellowship, quick context, is a paid program that works with diabetes advocates, so folks with lived or loved experience. It's a capacity building program where they're with us for just under a year, learning everything from advocacy to social media accessibility, communications, research, and most importantly, we work with them to take research, and they get to decide how they want to turn that diabetes research into a tool for their community members to be able to use this research. We know that the latest data, which is actually quite outdated, says that there is about a 17-year gap between health systems research being published to its application into quality improvement measures at scale. My hunch is in many places around the world, that's much larger, that gap. So really, the fellowship for us is how do we tackle that gap, but in a way that's led by people with lived and loved experience. It's evidence-based, but led by the community. And one of the projects this year was focused on the intersection of women's health, diabetes, and stigma, led by Marianne Maloney and Wajia Kima. I have to shout them out because they've done incredible work alongside Syra from Tide Pool as their mentor. So we're an all women with diabetes team working on this book. And we've put together essentially a book that across life milestones has things that women have told us that they've learned the hard way about that life milestone and either how to manage their diabetes or how to manage their life. But also, just as important, advice for clinicians and healthcare professionals on how should you be working with these women in this life milestone to treat them better and to see them as people first. Menopause second would be phenomenal. I actually see that of the attendees that are live with us today, there's at least 3 women in the room that have submitted lived experience stories. So thank you to all of you. We had women from all over the world submit dozens of stories, everything from experiences around puberty to pregnancy to cultural events management. How do I manage Ramadan as a woman with diabetes? What did I learn the hard way? But I also want to highlight that they also submitted stories around dating and travel and things that I think sometimes get left out of the conversation around women's health and diabetes because we assume that women with diabetes at best can survive, but we can leave the thriving conversation for another population. So, a few of the lessons that came from creating this book, it's going to be freely available, by the way, as an ebook online in a couple of months, and then we're going to print some copies to hopefully send to endos and doctors around the world. Very gentle nudge to have it in their waiting rooms. But some lessons that we learned the hard way in making the book. First, as we suspected, hormones matter way more than a lot of published research will lead you to believe. Just because women are figuring out how to manage their hormones by themselves doesn't mean that those survival mechanisms are enough. Like, we really need to do better at a systems level to not just acknowledge the intersecting reality of being a woman with diabetes, but do more research and mobilize that research into better policy, resources, and care, and especially better training for medical professionals. A lot of the medical professionals that we spoke to were like, I want to do better. I just don't know how. I don't even know a lot of these realities. And that brings me to the next point, which we learned that self-advocacy becomes survival. The medical professionals that knew about the realities about womanhood and diabetes knew because there was someone out there who took on the free labor to educate their healthcare professional and then wait for some potential help down the line for themselves. We should not normalize self-advocacy as a survival mechanism. Who has the privilege to even self-advocate? For every woman that we talk to that had the privilege to self-advocate, there are thousands that just don't have the capacity to do that. So that was a big lesson in creating the book. And another big lesson, I had to actually write down 3 because I had about 18, so I'm proud of myself for narrowing it down to 3, is that storytelling has to be seen as a legitimate, not just method of relaying expertise, but education tool beyond the diabetes community. So many of the women that we worked with said, well, I've been telling my story actually for years, but only to other women in the diabetes community. And of course, it's validating to be heard and to be seen, but we can't stop at validation within our own community. Storytelling has to go to medical audiences. It has to go to audiences that have the authority over our medical care. And yes, connecting it to the first question, my dream state is actually that women with diabetes are embedded in these decision-making ecosystems as partners of, education systems and medical systems. But I think we need to start with bringing people into our storytelling spaces that aren't women with diabetes and inviting allies and medical professionals to hear us and then to do something with what they're hearing. One thing I just wanted to note, though, is that was really sad in the process is the fear that people had around sharing their stories publicly. And I just wanted to highlight that. So many women said, I want to submit my story to the book. Can you publish it under a pseudonym? Because I'm afraid that I'm not going to get a job. I'm afraid that I'm going to lose this consultancy. I'm afraid I'm going to lose my dating prospects. And that's just, I think, a sad but very real reality that we have to name out loud because a lot of us live it, but I don't think people outside the diabetes community realize it.
No, that is so spot on. And I think this is why such sessions like these, where so many of us can be, so forthcoming, hopefully will help others to see that it's, diabetes happened to us. It has nothing to do with our ability to do our jobs or to thrive. I mean, these profiles, your profile and Renza, and even Dr. Nidhi and caregivers, et cetera, are fantastic. So hopefully that will help change the needle and change that perception and reduce the stigma that comes from being associated with it. And this goes for other NCDs as well, whether it's obesity or other chronic conditions, right?
Absolutely.
I want to build on this, and I want to go back to Dr. Nidhi. When we talk about the need to integrate lived experience into medical practice and the need to, have that, there's that gap, right, between what we go through day by day, and then what we get in terms of the care and the access and that awareness that needs to be built by professionals. How can we do more of that? How can the systems integrate more of that?
Very tough question. I just wanted to pick up something that Lindsay said, and you talked about being heard, and you talked about uh, advocating for yourself. I've come across in a lot of low and middle income countries, actually, and we were there. Jackie, you and I were there listening to some of these people in Hyderabad with this NGO that looks after type 1 diabetes. And the biggest problem they had was stigma. It was stigma around women being diagnosed with diabetes in the first place. So I do know that from a very small family foundation that me and my family support, which my cousin runs in Delhi. We support insulin for young girls. We don't give it to anybody else because we know if these young girls didn't get insulin from us, they would be left to die. So it literally is that stark choices in some countries that people have. Shouldn't be that if it's a boy with diabetes, they will get insulin somehow. But if a family can't afford it, they won't afford it for a girl. So, and the biggest problem that some of these girls had particularly, and Jackie will, I think, echo me on this one, right, Jackie, was the stigma that people won't even declare it, either in a school or anywhere else, because of the stigma that the girl might not get married or might not have a family or any of that. That is the bigger problem, actually, in some of these countries. So forget self-advocacy, forget advocacy. It's families as well making you hide that you have diabetes as a stigma. So that's a big issue in a lot of communities and a lot of countries. So I just wanted to highlight that as being a big problem. We live in a very privileged world, I have to say, but with some communities, it's a real issue. Jackie, I don't know whether you wanted to comment on that because that was a very stark choice that you and I heard, right? It's a difficult one.
Yes. Thank you for mentioning that, Niti. Yes, it was absolutely the most touching moments of our recent trip to India, where the mothers were saying that they would stay all day outside the school and hide the moment where they would put insulin for their daughters, or sometimes don't give them the shot at noon and wait till the evening, which is even dangerous. It's a health threat. So yes, it was really touching moment, but also a call to action to work more in that direction.
Yeah. Thank you, Jackie. So, I mean, I just wanted to touch on that because it stands out every time I talk to people across the world. But coming back to your question on integration of healthcare professionals training to into the systems that people understand what kind of care there are to give. It's a really hard one because the first port of call often in countries that I'm in is not the doctor. So again, that's an issue. It's not just about doctor, endocrinologist, or nurse training, because that's what we are used to here in Western countries. But actually, in a lot of countries, there's no doctor. The first port of call is often the pharmacist. It's actually where you go get your insulin from, where you go to your pharmacy to get some of these medicines. So I believe actually the dialogue has to shift. It can't just be about training healthcare professionals in hospitals and clinics. It's got to be about training community health workers, last mile health workers, using digital tools to sometimes facilitate that. It's not rocket science, some of this. It's got to be, so for example, in a recent project that I've been doing in Nigeria, with blue collar workers. We've been training pharmacists on 12 care pathways, of which diabetes is one. And again, there's a lot of female pharmacists, by the way, actually, in that country. And in a lot of countries, there's lots of female pharmacists. So again, it's about where patients actually meet, where people actually meet their healthcare professional, who those healthcare professionals are. We need to change that dialogue. Then we need to look at what training is required. And I guess the likes of Lindsay and Sarenza are your experts. They'll tell you from a person's perspective, from a patient's perspective, what it is that people want to see. I'd also like to tell you another little story of when I was a very young practitioner in inner city Birmingham. In my practice, there were 33 different languages spoken. You can imagine the challenges we had in some of the practice. This is in the UK, by the way. And we started something called structured diabetes education, which you guys are all aware of. The Daphnes and Desmonds of this world. This was new. Desmond had just been published. Daphne had just been published. And we were trying to get, and Daphne cost an arm and a leg. So I couldn't put it into place into my inner city practice in Birmingham. So I set up my own structured diabetes education program. And the first structured diabetes education program was delivered by peers. It wasn't delivered by a diabetes educator. And I nearly got sacked over this. So, everybody, the whole diabetes world thought I was bonkers and crazy. And they were like, you can't do this. Peers can't teach people, diabetes education. But they absolutely could. And my life lesson was on this one woman that we did structured education. She went on to be a trainer. She couldn't read or write, by the way, this lady. She could only speak Punjabi. She couldn't read or write. And she had lived in inner city Birmingham for about 15, 20 years. And it's the first time anybody had taken the time to actually ask her what mattered to her in her diabetes care. So she actually went on to train lots of other women in a Healthy Communities collaborative that we set up. And she challenged the National Clinical Director for Diabetes. Her name was Sue Roberts, if somebody might remember her. She challenged her. She came to my practice to see what we'd done with peer education. And she saw that. And this woman challenged her. And she said, why didn't you put it into place in my language, in my cultural aspect, and teach me how to look after my diabetes better? She was the best advocate I ever had. I didn't have to say it myself. She did it for me. So I think when you're talking about that's just an interesting story, but I'm just telling you how when you integrate care and you integrate people's stories, you integrate how education is delivered, it's got to be in the last mile. It can't be sitting in a fancy hospital which has about 5 people coming to it. It has to be where you've got to meet people where they are. So I think when medical education changes or health education changes, that's what we've got to focus on, because that's what the world relies on for their healthcare. And there's so much more that can be done. The pharmacist can tell you how to store your insulin. They can tell you how to keep it viable. They can tell you how to do your blood test. They can also tell you when to do it. You can come back to the pharmacy. If you don't have a glucometer, they've got strips there. You can come and do your blood test there. So it's very, very simple stuff, but I think we're starting to learn what that might look like. I hope it answers some of your questions, Sylvie. I don't think I'll ever be able to answer it fully.
No, but I think it's so interesting, and I love the idea of flipping the narrative as to who we're training, right? And to go beyond just the healthcare provider, because we have so many other points, like you mentioned, the pharmacists and others. And I'm remembering from my own journey when I was first diagnosed, I had a great endocrinologist, but it was somebody that I was introduced to who had been living with type 1 for 10 years. She was my best source. And then I realized we needed to have more of this peer-to-peer support networks. And that's one of the reasons that led to the creation of DiaLeb, because I was searching for that myself. You go online, there's only so much information available, and then lived experience, loved experience is so much more powerful, right? And when you find people that you can find yourself close to, it's incredible. And I think what you did with this lady was empowered her to basically what we're saying we should be doing with this webinar. I want to go back to Renza. And just, I mean, you've been an advocate for so long, and we're just talking about this idea of how we can shift the script by allowing women with lived experience to be truly included in the rooms. Have you seen from your work, any positive experience or any models that we could replicate and do more of?
Yeah, I think we need to shift the language around allowing, though. I think that means that we're sort of, I guess, asking for permission to be there rather than it being an expectation that we are not only at the table, but as Lindsay said, we built the table and it is our table. I think that there have been a number of different models that have worked very well. Lindsay's example in Canada is significant and it's beyond Canada. I mean, I think Lindsay undersells herself when she says that that's where she works. The work she's doing is resonating globally. I think DDoC has ensured that through the DDoC Voices Scholarship Program, people with diabetes are now in force at global diabetes conferences, which has been a very important and a very big shift. I think where we need to move a little bit perhaps, and where we certainly have started to do that, is that, just as in the past we've started to really not accept, I would like to say that this isn't a thing anymore, but of course it still is, but, the idea of manels, men-only panels at diabetes conferences. I think we're getting to the stage now where we also recognise that we can't only have clinician and researcher panels. If we're talking about diabetes, we have to have people with diabetes at the table. And this, it's really interesting because I frequently have been the one who's ticked the, oh, look, good, we've got a woman on the panel, and good, we've got a person with lived experience on the panel. Yeah, that's great. But I think we do need to make sure that we do this in a meaningful way and not just in a window dressing, very token way. And there certainly are things that are being done to, I think, challenge that. You know, I constantly say we look to the allies because they're the people who are looking to make a change. So, you know, if we look at how Chantal Mature really engaged with DDoC, for example, at EASD, it wasn't just the Voices Scholarship Program. It was then making a commitment to having people with lived experience on guideline committees and you know, central to that work. You know, those sorts of initiatives are how we do really start to make an impact, because we need, you know, once we see a normalization and these sorts of these sorts of ideas are really embedded, they do become the norm. They become the expectation. And I think that that's where we need to get to. This needs to start being that question of, well, hang on a minute, where are the people with diabetes? But that needs to be not just a responsibility of one person. And you know, I was that person for a very long time in diabetes organizations that, you know, it sort of was a bit of a shock to me when I moved to Breakthrough a couple of Breakthrough a couple of years ago, to understand just how embedded lived experience is in the organization. And it's not just the fact that they've got a significant number of people with type 1 diabetes and people with lived experience of type 1 diabetes in the buildings. It's also the connection that those people have with the community as well. So the thing is, it's very deliberate and it needs resourcing. So from an organization perspective, I think that it's not enough to have a community advisory council. So quite frankly, community advisory councils are probably one of the ways that engaging people with lived experience, it's really done us dirty, really, I think, because often organizations say, we've got a community advisory committee. This is really brilliant. You know, it's great. We've got these people with diabetes. They meet 4 times a year for an hour, perhaps. They're handed documents when they're ready to be printed, or a campaign when it's ready to go live. But it gives the organization license to say, oh, we engage. We are completely driven by lived experience. People with diabetes are at the heart of everything we do, and they are the ones who drive everything we do. Look, we've got a community advisory council, and you can point to that. And it's actually quite offensive that anybody's being allowed to get away with that. And I constantly say that the burden of proof around what that real engagement is, where that real, you know, people with lived experience, women with lived experience being there as part of decision makers with an ability to influence, the burden of proof of that should not be up to us to constantly challenge it. It should be for the organizations to show over and over and over again how they're doing that in a really meaningful way.
That is spot on, and a lot of the
Can I
times
make a short bracket? Sorry.
Sure.
I just want to comment on what Niti mentioned earlier about training the healthcare professionals. And second you with that, we believe so much in it at DiaLeb that we have trained dietitians and nurses, and dietitians and nurses are like 95% women in that field, you know. But furthermore, we have been training volunteers because we believe that they are a powerful tool to raise awareness in the community. And also, I would like to second Renza in mentioning the great work that DDoC is doing. But furthermore to that, I'm very happy, and Niti will also corroborate that. The International Diabetes Federation has a person with a lived experience on every stream committee in preparation for the 2027 Congress. This is also something we've been keen to introduce, and Niti is a pioneer with that.
Thank you, Jackie. I think it's really important that we hear that. And about your community volunteers, it's very important too. So we had something called the Healthy Communities Collaborative wrapped around my practice, mostly women. who took services in and out. And it's not just diabetes services, also screening. We increased our screening services for women for cervical cancer and breast cancer, where, it was down to 31% actually. And when we had these women go out and volunteers go out and actually activate communities, it went up to 76%, the screening rates. So it was just very stark on how some of this happens as well. You're right, Jackie.
I think that, having that community and that lived experience involvement is really, it's essential. When we look at campaigns that have worked well, they have worked well because people with diabetes have really made sure that they are going to land well in the community. But, one of the challenges that we have is that we rely very heavily on community members, people with lived and loved experience, to do this on a volunteer basis. And I think we do need to really look at how we do this to very much, respect the work that people are doing and to recognize that in a way that includes reimbursement.
Well, I totally agree with you, Renza.
Yeah.
I think this is a big issue. I remember on panels, and my son, who's a very outspoken advocate, got really cross.
Why would that be the case? Where does that
I don't know. I have no idea. He got really cross once because everybody this was EMA, this was the European Medicines Agency that was looking for diabetes support and diabetes voice, would reimburse everybody but the person with diabetes.
Oh, that's
It's
right.
ridiculous.
I know.
Yeah.
I can't tell you the number of times I've been on a panel
you're
where that's
reimbursing
happened.
a doctor for his time or her time. The person with diabetes needs it. You've got jobs, you've got things you do. You're not just there with people with diabetes. You're actually humans that are doing other things too. So I think I totally agree with you. I don't think that has actually landed in any of the patient organizations that I know. It's not just the diabetes world, but I think it's a really important point you raised, Renza.
If I could just jump in really quickly around that point. So at Diabetes Action Canada, we actually don't do any engagements that are unpaid, and we don't even promote engagements from the outside world that are unpaid. And actually, why we do that goes beyond reimbursement. So on the topic of language, reimbursement, I think works if you have a job title, a contract, and a salary. But if you are someone who is at the table with lived or loved experience, it's not quite the same because for you, first, time is a barrier. When you are an advocate in a space, time is not an enabler of your work, the same way as if I show up with my work hat on, time enables me to do more work. If I show up with my diabetes hat on, which is actually always on, but that's a different topic of discussion, time is a barrier. It doesn't enable me to do better. It actually sucks energy and resources. And I think when you're a woman on top of being the person with diabetes at the table, we've seen time and time again that time is an even bigger barrier for women because they're holding these invisible caregiving and caretaking roles. So one of the key reasons why at DAC everything is compensated is because we understand that if we were to start even trying to quantify reimbursing someone's caregiving or lived experience time, it's quite literally impossible versus we can say, okay, there's an hourly rate to expertise for consultants. So can we then work off of that as a model, co-design our rates with people with diabetes and work off the assumption that time is a barrier and we're going to reduce that barrier by physically meeting you where you're at, having meetings at 11 p.m., not at 11 a.m. because you're on your shift at 11 a.m. or you're feeding your kids at 5 p.m. And then paying you so that we can reduce one barrier in the way that we engage together. I think that's a really critical, I think as a field, we say we've reached that point. I don't think we have at all, Nidhi, to your point. Like I have a recurring line with some of my other female colleagues, and we always say, I think one of them's actually on the call today. The bar was so low, and we continue to be impressed by how much lower we can get. It is impressive, So
I think, it's one of those where you talked about the frameworks, Lindsay and Renza, and we talked about the systems with the Nidhi, but it's really one of those cases of we measure what we value, right? We compensate for what we value. And I think when we truly have that shift, it's when people will start to really value and not just take it for tokenism. So I value 100%. Everything you're both doing. And I wish you all the success in continuing, because it's an uphill it's an uphill. It's not a battle. It's an uphill. I know it can be low sometimes, right? You go down, but then you can go back up. And it's great to see all the work that you're doing to support this. I wanted to ask one question that we've gotten on the Q&A. We've gotten two, but they're pretty interlinked. And I guess it's mostly for Niti and maybe Jackie, which is, what advice would you give mothers who take care of children with type 1 diabetes for taking care of their child, but also their health?
That's an interesting question. I can go for it a little bit, and Jackie can tell you. I don't know what whether she wants to embarrass you, Sylvie, but I don't know about that. I think it's a really tough one, right? But you just have to be as normal as possible, because if you're not, your kids are just completely, Jerry didn't know any better. He was 4, and it was literally living with the condition since he was 4. But if I had made a drama of it, then it would have become a drama forever. So you have to tell yourself not to let it become a drama with you. And I think that's a really hard one. You need a lot of resilience for that. It's a family unit. It's not just the mother, I guess, is what I would say. Involve everybody in the care. My older son was involved in the care too. I don't know whether it was a good thing or a bad thing for him. Husband and the rest of the extended family. And everyone else around you. You just have to tell people around you and involve everyone around you. I remember having a very interesting conversation. I used to have a lady who used to pick my kids up from school, was a working doctor at the time, pick the kids up from school, and she's terrified of injections. So she would never give Jerry his shots. There was no pumps in those days. But my cleaner, who was a very, very pragmatic Black country lady, said to me, well, teach me how to do it. Can't be that difficult. So it was Iris that I taught how to do his injections and do his blood tests. That time it was finger pricks and injections 4 times a day. So it's also involving everybody else around you to actually, and devolving some of the responsibility to others and trusting them. That's what I ended up having to do, and to learn to have to do that, because you're kind of almost wanting to be in control all the time, but you can't be. So you've got to let the others help you and do that as well.
I mean, I guess the parenting journey it takes a village. They don't say that for no reason, and it takes even a more connected village for any parent, I would assume, with a child with type 1. I've noticed the time, and I know it's such an interesting conversation. We could, I think, talk for hours. But as we are getting close to the hour, I wanted to ask one final question from our panelists, maybe just, or anything you wanted to highlight before we end today's discussion. But really looking for what gives you the most hope today as we look at the future for women and girls with diabetes. Lindsay or Niti, since you're unmuted, maybe you can go first.
Yeah, so gives me hope that we're doing this this webinar in the midst of bombs flying around you. So that's my biggest hope. You've got these 2 wonderful women, Sylvie and Jackie, who've had the courage and the strength to stand up and actually do this webinar because it's so important to you. So that's my biggest hope today, and I shall take that away as a golden nugget and hug it before I go to sleep tonight.
Thank you so much. Renza or Lindsay?
Yeah,
Renza?
I think that a lot of the conversations that we're having, where we're really recognizing, I think, the work that women do in our community are really important, because so much from that community grassroots perspective has been powered by remarkable women with diabetes. And we have to have that conversation. There has to be a layer of that so people understand it's not just a little hobby on the side. You know, I genuinely believe, and I agree that it shouldn't be, as Lindsay said earlier, but living with diabetes is an act of advocacy in itself. But to
100%.
do these sorts of, to take this on is really quite remarkable. And I feel that we need to do a better job of really recognizing what that labor is, the trauma that's involved in it. Every time we're asked, or we do relive our story of diabetes and some of the particularly difficult times. But I have hope that's being recognized, and that the women who are doing this, are hopefully going to get a lot more support in the future. I think that that's something that we need to really look to, is how we can support these initiatives to continue, because people do burn out. Burnout is very real in the advocacy space and in the volunteering space. So I think, though, now we're recognizing that, and I hope that that's the first step to actually meaningful change, to look at how we can support people doing that and look at sustainability for these sorts of programs as well.
I mean, women with diabetes are the funniest people I know. So Renza, to your point, it's got to be the trauma. It has to be the trauma at that point. But what gives me hope is that Nidhi said that she almost got fired for her program. All the coolest people that I know doing cool things, especially in the diabetes world, largely are women with diabetes, largely have almost gotten sacked at one point for doing something against the grain that was the right thing to do. So that gives me hope, because it means that we didn't get sacked and we're doing cool things that are making life better for someone every day. So, yeah.
I'm going to join you before you close, Sylvie, and tell you that what should give all of us hope is seeing women like you doing what you are doing, being who you are from wherever you are standing, and being the voice of those people who maybe can't or don't have enough circumstances, favorable circumstances, to raise their voices. This is what gives me hope. And thank you all so much from my side. And I give the floor to Sylvie.
Thank you so much, Dr. Nitipal, Lindsay, Renza. You're so inspiring in your own ways, and your insights have really been so interesting to me, and I'm sure to all of our listeners. And I'm sure many women and men around the world who are listening to this will be inspired to just be a little more mindful and a little more empathetic, and to the plight that, and the issues that face women, especially women living with diabetes. We heard a lot about systems. We heard about stigma. We talked about innovation, about frameworks. And what connects us is that the reality is, as women with diabetes, we're not asking for any special treatment. We're asking for intentional design and a seat at the table that we create, like Renza said. So I'm going to use that quote from now on. We don't need permission. We belong there. And we hope that there can be policies that are designed that account for the caregiving burdens of women, that research agendas that include women at the design stage as co-authors, language that heals rather than harms. At DiaLeb, our commitment has always been to continue to build bridges between patients, policymakers, healthcare providers, the communities, not just in Lebanon, but around the world. So thank you so much for being the change that requires all of us to work together. Let this International Women's Day not just be a celebration, but a turning point, because when we empower her health, we strengthen families, communities, and entire health systems. Thank you so much to each and every one of you for being a part of this movement. More power to you. And thank you to all our listeners for being here today.
Thank you all. Stay safe.